All right. Well, I'm going to go ahead and get started. We got 79 people, and more people are popping in all the time from right there, too. So I'm going to go ahead and get started, everyone. Good afternoon, everybody. Thank you, first of all, for working through our slight technical issues. We had the first time we tried this and we put this together really fast because we want to be very respectful of Chris's time. And we know, sadly, that Chris is probably going to get more busy than less busy as time goes on. If you don't know, I'm Paul Price. I'm the Science Department Chairman at Trinity Valley. I'm also a Trinity Valley graduate. And Chris, Dr. Chris Champion, who's with us today, is one of my former students. In fact, he graduated from TVS in my first class of seniors in 2002. After that point in time, Chris went to Duke University, where he majored in biomedical engineering. And after that time, he went to the Baylor College of Medicine, where he got his MD degree and actually got a dual degree, waiting an extra year, if I remember correctly, for his wife to graduate along with him. Got a dual degree, his MD and his MBA from Rice, a dual degree from those two institutions in 2011. And since then, he has worked his residency in emergency medicine, and he currently works as an assistant professor of medicine at the Vanderbilt University Medical Center, and also works with the VA hospital in Nashville as well. So Chris, thank you so much for joining us today. Let me give you no problem. Let me give you kind of a heads up on how this is going to work for our participants. You should see in the webinar, you will not have the ability to speak. You only have the ability to type in. You can chat to us as the panelists, but primarily what we would prefer that you do is that you should see there is a Q&A box for you guys to work forward, and you can type questions directly to me that I will then moderate and send to Chris via the Q&A box. We have some questions to get started, but we really want to use this time as well for you to have your questions answered, and we're just going to kind of go free flow after about 3 or 4 questions that we have moving forward. So again, if you have a question for us, please use the Q&A box. Larry Kahn, who's our Director of Technology at Trinity Valley, is also moderating the chat window as well. So if you have a technical problem or some other issue, feel free to hit that, and Larry's going to be looking at that as well. So Chris, I think from the conversations we had earlier, the first question that was on our mind, I think on a lot of people's mind, is tell us what's life right now in the ER. What's going on in the ER? What's your daily life like? And what do you expect it to be like in the next week or so as we move forward?
Sure. So I think I'll put a caveat being that while I work at Vanderbilt and VA, my thoughts here are basically my own opinions, and they don't necessarily represent my institution. But I think right now, when you look at emergency medicine, when I was like, what is the number one, if I was to put one word, what would be is going on is that it's change. Basically, I think we're undergoing the fastest, most rapid change of medicine definitely in my career, definitely in this millennia, in response to this. So the way I last worked like an overnight shift 2 weeks ago, and the way my overnight shift that I'm going into tonight is going to be compared to 2 weeks ago, it's almost like a totally different emergency department. Everything from when you walk into an ER, there's a person there now asking you like, are you having a cough? Have you got a fever? Do you have a runny nose? Oh, if yes, you need to go somewhere else now and not into our main triage area. To every single patient I see, I'm like, does this patient possibly have COVID-19? Do I need to put on all of my PPE? Seeing everyone wear a mask, which is not something that we did normally, to everything changing on a daily basis. So like just even things that we like, how do we put a breathing tube in? No, we've just totally revamped our entire protocols around that in order to protect everyone from COVID-19. So it's one of the fastest, most changing things I think I've seen in medicine. It's changing faster than published literature can come out. We used to say that, if you wanted to be on the cutting edge, you read published literature in New England Journal of Medicine would be like a few weeks, a few months behind. And then you kind of talk to the people who are doing the literature to get more ahead. Now it's almost like you are paying attention to what is coming out of Twitter and social media from Italy and China and trying to react to those comments and data as people are collecting data on these things before it even hits the published data. And then also, incorporating published data into what we're doing. So I think that's the biggest theme of everything is change. I think there's also, for frontline workers, there's a little bit of fear. It's interesting that 2 weeks ago, we started look, everybody who checks in with a cough, we're gonna start wearing a mask, we're gonna have a face shield, we're gonna have a gown, we're gonna put on gloves. We may be wearing cappers, which are more advanced than the masks, like positive pressure systems. And everyone's like, do we really need to do all this? And about 48 hours later, as we started getting more data, everyone's like, yep, we need to do this. This sounds like a great idea because none of us want to get coronavirus. I mean, simple things like I sit down at my desk and you would think we would do this regularly, but like some of us always have, but like I clean off my desk and the phone and the monitor and the screen and the keyboard and my phone, and I wipe it all down with things that kill like everything. And I do that multiple times a shift over 8 hours. And then, you know, that last portion of it is like, how do I just like getting into my house has changed from work. I used to wear scrubs that I have on. I would go to work. I'd wear these my whole shift. Maybe I get a little bit of blood on them. If I got a lot of blood, I'd change clothes while I'm at the hospital. But if I got nothing, I'd come home. I would, you know, calmly go upstairs, say hi to everybody, change, not like immediately, but in a relatively short period of time, and throw them in the wash. I like a special laundry bucket for them because they're not exactly the cleanest coming from the ER. But now it's like, I go to work, I'm going to change into hospital scrubs. I'm going to do my shift in my hospital scrubs. And then I'm going to go back, I'm going to change out of the hospital scrubs, put those in the hospital bucket. I'm going to put these scrubs back on. I'm going to come home. I'm going to change in my garage. I'm basically going to strip down to my underwear. I'm going to put those in a trash bag. I'm going to go inside. We have bleach wipes. I'm going to wash down all of my equipment, like my phone, my wedding ring, my watch. Then I'm going to go upstairs, not say hi to my kids, try to run past them, and go directly into the shower. And it's to like literally there's a debate among a lot of my faculty on when do you just pull a trigger and decide that you aren't going home anymore. And I don't think any of us are there yet. And there's a lot of pros and cons to that. Like my wife would be at home with the kids. My wife's also a physician, so we've had conversations of would she not go home. There's a lot of responsibility. We have 3 kids at home, a 5-year-old, a 2-year-old, and a 3-month-old. So trying to protect them, but we also have to teach them school now because they're not in school. So there's a lot of responsibilities beyond that. And then probably the biggest thing that the reason we haven't pulled the trigger on it is when does it end? Which is the conversation that a lot of us is like, when is this going to go back to normal? But when would I pull the trigger on, okay, it's time for me to go back home. So those are kind of all the things I think people on the front lines are thinking about, and kind of what we're dealing with. So.
Okay, it's a way, and of course you haven't really hit the crush yet that we're seeing in some other cities.
No, yeah.
Well.
So right now, I guess right now in the ER tonight, I'm anticipating it'll be relatively, I'm going to use the word I'm not supposed to, but slow from the superstitious level. But we think in the next week to 10 days we're going to get really busy. So, but right now it seems almost like the calm before a hurricane, the receding waters before a tidal wave. People who normally would be coming in with things aren't coming in. And then I will say that almost every patient I see has some level of respiratory, like cough or something like that, it seems like. So.
Okay. Well, to move over to there, I think a lot of questions that you and I talked about before and has hit up a lot with me in conversations this morning and yesterday is the confusion or discussion of coronavirus versus the flu. We've seen a lot of things in the media saying, of course, that flu is going to kill, the lethality rate, total lethality of flu is going to be much greater than coronavirus. Could you talk from a medical perspective for a bit on what exactly is a coronavirus and why are we so worried about this particular virus relative to, to diseases we deal with on a yearly basis, such as flu, or, swine flu going back to H1N1, or some other perspectives from there? Could you give us your
Sure.
expertise on that?
So flu is a bad virus. I'm not a huge flu fan. It's not like something I'm super excited about, but it's a bad virus. But to put it in perspective, I think probably the 2 most recent things that people here can remember is 2009 H1N1 pandemic, as well as, believe it or not, the 2017-2018 flu wave, which maybe didn't hit the media as much. The 2017-2018 flu wave probably killed more people in the United States than the H1N1 pandemic did. And so I actually pulled up for this talk about just like H1N1, the CDC recommends in hindsight, probably 60 million people got it over the course of that April to April kind of time span from 2009 to 2010. And there only were 12,469 people who died. So if you do the math on that, it's not like 0.1%. New York Times reported that flu kills, probably 0.1% of people. And that I think is a really, 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 really bad flu, could maybe get up to that point. The 2017, 2018 pandemic, which was, just a couple of years ago, where did it go? We had maybe 61,000 people died from 45 million people infected. And so when we look at the mortality of that, it's not 0.1. It's more like 0.001 or 0.0001, somewhere in that kind of range for these usual kind of flu waves. In addition, flu has an R naught of 1.3. So R naught is a mathematical number of how contagious something is. And so what that means is every person who gets the flu in the United States, because R naught varies from country to country, region to region, as well as what interventions are being doing on, and is dynamic. It's a dynamic number. It's not fixed. But in general, R naught for flu is roughly 1.3 in the United States, with the amount of people who get vaccinated under a normal year. That means every one person who gets the flu gives it to 1.3 people. And sometimes they don't give it to any, like if you're the last person in your family to get the flu and you stay home because everybody else got sick, you probably didn't give it to anybody. So you'd get a 0 on the points, but then somebody else, brought it home to the family and gave it to everybody else in the house. And so they got 4 points. So, but coronavirus is hanging out somewhere between 2 and 4. Probably, I think the best numbers I've seen were like 2.5 to 3.5. So it's twice as contagious as flu. And there's a lot of things that it does that flu doesn't do, which are also unfortunate. But the other thing it does is it has it has a mortality which is significantly higher. It's not 0.1, it's not 0.01, it's like 2 to 4%. So, and that's a best guess right now. I think World Health March 3rd last updated and said 3.4. And so that's at least, in the best case, compared to a really, really bad flu, 30 times as bad. And if you're talking about other regular flus, it could be 300 or 3,000 times as bad. I will say that that mortality number could go up, it could go down. No one really knows. But it's definitely way more contagious than the flu. It's much more dangerous than the flu. And finally, this virus does things that flu, I actually don't know the data off the top of my head, but this virus is so contagious. Reason we have to wear a face mask and a face shield and a mask and gowns and gloves is that you can cough it into our face. We can breathe it in through respiratory droplets. We can pick it up from surfaces. It lives on surfaces like plastic for 3 days. It lives in the air for 1 to 2 hours, according to a recent New England Journal article. So I don't know exactly how contagious it is, 3 days, but we can still detect it on those surfaces. And so that means that every patient who comes in, we're having to wipe down everything, we're having to clean everything, and it makes it, it's a pretty difficult disease to prevent infections. In a hospital setting, it can very easily run amok, and it can definitely be contagious from people like out in the community.
Let me expand on one part from that. Of course, one of the things we're also hearing about COVID is the fact that it seems to be, in terms of the mortality rate or the severeness of the infection, seems to be higher, of course, in our more elderly population. Do you think from things you've seen or things that you've read that the incidence of greater danger is going to end up being higher for younger populations than we originally believed?
I mean, I think it's definitely
stop there yet.
It's more dangerous in old people. I mean, flu is also more dangerous in old people, except for H1N1, which is kind of a little bit of a different flu than normal. But most old people, when they get a respiratory virus, and we haven't figured out why, but there's still, to my knowledge, not been anyone under the age of 9 who's died from coronavirus yet. There's been a handful in the 10 to 20 range, in the 20 to 30 range, but even those mortalities are 0.2 or 0.1 or 0.3% of the population. That's 1 in 500, 1 in 0.2. That's still higher than a typical flu, like at least double. And the flu, remember, still is really targeted towards those old people. So old people mortality is significantly higher, and it's especially above 50, above 60. And when you get to the 70, 80 range, it can get very high percentages. A lot of those people need to be hospitalized, which then leads into a resource problem. And so it's definitely much more dangerous. So.
Yeah. Let's spin, because we can go in a couple directions here, and we're getting some good questions in as well, and I'm trying to incorporate those through our discussion. So please keep sending your questions through the Q&A link on top of that. Let's talk for a minute about PPE. And if you could talk for a second about, I know you mentioned briefly what you had to do in terms of PPE. Right. I think the two biggest question is, how does your PPE change? I mean, how much of the PPE can you wear on a normal shift that can make it through the entire shift? How much does it have to change from one person or from one patient to the next? How much PPE do you have left right now? And of course, there's been a lot of conversations about a lot of, at-home movements for generating extra PPE for hospitals and doctors and so on. What's the actual thought on how that might work moving forward?
So PPE is really interesting. So like 6 months ago, everything in the hospital is everything's one-time use and we throw it away. So like I have a mask on, I go see a patient, I take the mask off and then throw it in the trash. Every now and then you might reuse a mask between like a couple of people in a row, but in general, everything is designed in medicine to be one-time use so that you don't take an illness and transfer it to the next person. So face shields, for example, not something that was regularly used for a lot of different conditions. And then we decided we need to use face shields for these outside of like operating rooms or areas where people like get splashed into their eyes. And so we also have a lot of like one-time reusable like plastic sheet gowns that you kind of tear off. So all of this would be used once in the course of seeing someone. And then gloves, I mean, I just reviewed our intubation standard operating procedure to get, getting into my stuff, I use one set of gloves. And then when I get out of my stuff, to clean off the equipment that I use to do an intubation, which involves a PAPR or a CAPR equipment, which is a positive pressure device. It's like basically above an N95 because it doesn't prevent anything from getting into my face. It provides a shield as well. In order to clean that off, I've got to use and get out of my equipment without contaminating myself. I got to go through like 4 sets of gloves. And so you can imagine that very quickly in a single-use environment, you're burning through a lot of equipment. And so what we found was, all right, so everybody who might have COVID, let's go ahead and do what we call now enhanced precautions, which is the face shield, a surgical mask, some like contact preventing gown and gloves. And then all of a sudden our hospital's like, you guys are burning through our face masks really, and our face shields very, very quickly. So we almost immediately had to go to reusing these single disposable face shields, which they've held up fine, but it means you walk out and you wipe down your face shield in order to keep it. And in addition, we try to keep our masks on for almost the entire shift, unless you touch it or contaminate it in some way. So we try to like prevent contamination of our equipment. We're still using gowns, or almost single use, unless you're going like directly from patient to patient with known coronavirus. In which case you can cohort them and you can reuse PPE across those people because they're all doing the same thing. We just end up changing our gloves in those cases. In terms of the CDC has a lot of guidelines right now. This disease is somewhere between, we're talking about infectiousness and PPE. In hospitals, there's kind of like 2 standards. There's like airborne and droplet. I guess there's also contact, and there's a couple others like neutropenic. But this disease probably exists somewhere between a true airborne virus, something like measles, and a true droplet virus, something like tuberculosis, in terms of how small the particles are that it can transmit itself through. We like to break everything up into concrete bundles. It's probably on a continuum, which is why when we do certain procedures, we treat it as if it's an airborne virus because we make it airborne. So when we do an airway, like you put a breathing tube down someone before we put them on a ventilator, we're going to pretend this person now has an airborne virus. And we're going to treat them as if they have an airborne virus. But if somebody just comes in with regular COVID symptoms right now, we're treating them more as if they have droplet. So there's a lot of variability about that. Part of the guidelines and recommendations from the CDC are acknowledging that we don't have enough N95s to give to everyone. And so there's, like the guidelines are changing. We're trying to see if we can get away with surgical masks. And there's some data behind those recommendations that surgical masks are good enough from South Korea, which is why I think that recommendation happened. But there's also concern from other people that are they making this recommendation just because it's what we have and we don't have any other choices. So there's a lot of debate around that. And then homemade masks, I've been reading a little bit about this. I don't know, there's been some studies on homemade masks in the past on like, it's old data, but are they really helpful, like with cloth masks versus not? I think, is it probably better than nothing? Probably. I hope it never really gets to that point. I do think cloth masks would be really helpful in terms of you preventing, if you have a disease, preventing someone else from getting it. One of the most important things we do to prevent this from spreading is if you have coronavirus or we think you have coronavirus, we put a mask on you. And that just helps almost immediately contain you from spewing out coronavirus particles into the environment. So.
We're getting a lot of questions, and I want to get to social distancing in a minute, and we'll kind of lead into that. But we're getting a lot of questions right now about people who are concerned about where their businesses have been deemed essential. And of course, in Fort Worth, we're right now in the scenario that if your business is not essential, you've basically been told to shelter in place. But of course, the definitions of essential are fairly broad, not just for the medical profession, but auto repair shops, et cetera, are deemed essential.
Sure.
And people are wondering, like, if I'm going to the grocery store or if I'm bringing home a package or something like that, what is the best way to decontaminate things or work through things to avoid cross-contamination or something like that? Do you have any recommendations for people as they're, obviously sometimes there are visits out with other individuals you're going to have to do? What would be your recommendation for those individuals to try and prevent, obviously, exposure when you're forced in a larger environment, or if someone brings you an Amazon package? Or is it still, in your opinion, is it still safe to go get takeout food from McDonald's, or of course you're in area Chick-fil-A or something such as that? What would be your general recommendations from that perspective? And how do you also prevent, you've got someone going into the hospital, say for a non-COVID case, how are you preventing that cross-contamination within the ER itself? Is that primarily the mask there too?
Yeah, so for going out in public, I think the CDC guidelines of trying to maintain 6 feet of social distance is probably the best thing to follow at this point. We can argue if 6 feet's enough or not enough, but I think it's a reasonable number that's maybe achievable. And then just for notice that when you consider a contact with CDC defines a contact as 10 minutes of sustained exposure to someone with coronavirus for a 10-minute period of time within 6 feet. So just because for example, we've had a physician who had diagnosed with coronavirus. I saw him the day he was symptomatic. I only interacted with him from about 3 feet away. I said hi, and I moved on to doing something else. I don't consider that an exposure, and I'm 10 days into this and I don't have any symptoms of coronavirus. And my hospital isn't making me do anything. I'm still going to work. We're wearing a mask all the time right now just because of our risk. But there's nothing else that I would do differently about that. But at the same time, it's somewhat making sense. We've got takeout a couple nights ago at our house. Do we wipe down where it's delivered from? I think you could if you really want to. I don't know if you necessarily have to, but it does sustain on surfaces for a long time, which makes it challenging. It's kind of this vague land. When I went to the grocery store, I definitely wiped down the cart before I went in through the grocery store with a Lysol wipe, just because I don't know who the person who did it before me. I know some grocery stores are making a strong effort to wipe down all their surfaces after, every day, but you just really don't know what you're dealing with. And so I think there's definitely a risk going out to the community. It's non-zero, but I don't know what else. I don't know if there's anything else we can really do beyond just being very aware of the surfaces of what you're getting, as well as wiping down and making an effort to stay away from other people. And then what was the next part? Oh, preventing people in the hospital. Yeah, our main goal is this is challenging because, out front, they'll say, I don't have a cough, I don't have a fever. And then this happens in medicine where people think about it. They're well, actually, I did start to have a cough, yesterday. So we try, though, that's the whole goal purpose of our person up front, is to immediately try to put you into do you think you possibly have COVID category or not? And then even in those people who possibly have COVID, some of them just it's cold and flu season still. So most of our people that have COVID-like symptoms really just have other illnesses. And we don't want them to get coronavirus. So we're trying to, set up a situation where they still have 6 feet between them. They're all wearing a mask, which greatly reduces their likelihood of giving it to someone else if they do have it. And then trying to put them all in individual rooms instead of just putting them in a hallway or in a room with 20 other people. So that's kind of, I think, our main goals. And then other thing too is after every patient, we mark every single person who we think may have COVID. They all get the enhanced precautions from us, which we kind of talked about. When they leave, we make a very good effort to kind of clean that room up to make sure it's ready to go for the next person. It wouldn't spread it to somebody else, because we know that the next person that might go into a room who maybe has suspected COVID could be someone who's immunosuppressed, and we don't want them to get it. So.
Let's talk more about social distancing on top of that. So could you, because as I said, I think we're we're starting to see a beginnings of more cases here in Dallas and Fort Worth. I mean, I think this morning I read, and this information is probably already old. We're well over 70 confirmed cases in Fort Worth and 100 plus in Dallas, moving forward. But we're not seeing the numbers yet here that we've seen in Washington State or in New York, for example. Could you talk more about the importance of social distancing, particularly now? What the reasons are why we're social distancing, and situations such as the social distancing not just mean, we're not getting in large groups like going to school, or today was supposed to be opening day for baseball and things moving from right there. But in terms of social distancing, like a play date for, one family or another family from right there too. Could you speak to that to some extent and talk about the importance of social distancing, particularly from the healthcare perspective, why, from preventing the storm and flattening the curve, and then what really should be allowed and not allowed right now too? What, if you had total control of distancing in the country, what would you do?
Oh man, if I had total control. So I'll start with social distancing and flattening the curve. So as of in the last 30 minutes, the US now has more cases than any other country in the entire world, according to Worldometer. So that changed while this webinar was going on. The curve, so the thing to remember is that everything you do today is not affecting what happens tomorrow or the next day. It is affecting what happens in our hospitals in 10 to 14 days. And so the next week to 10 days to 14 days, the disease, what's going to happen and hit our hospitals may already be set. And there may be nothing we can do to prevent that, which is the scary part. And so when you look at China, who's had a lot of experience with SARS and other outbreaks, when they had 143 cases in their country that they'd identified, that was when they implemented their relatively draconian Wuhan lockdown. And they still ended up with 81,000, 60,000 cases and kind of trickled to 80,000 over the next several months. You're talking about, Dallas, Fort Worth already seems like a few hundred. Tennessee, where I'm at, we just hit 1,000 for the entire state. And the downside is, similar to China, which didn't really have a great test when it started, trying to identify what this case is and testing about it is, you don't really know what's happening. It can be, we don't have a good idea of where we are. So unlike South Korea, which was able to implement a massive testing campaign, they actually have pretty good data on who had it and who didn't. They have more data than a lot of countries that, because they're able to, with their excess amount of testing, able to more rapidly initiate interventions, I think, which kind of helped them kind of decrease their curve. The more information you have when it comes to testing allows you to more rapidly make the decision on we need to close the schools and all those types of things. Unfortunately, we don't really get to test until most testing in the United States doesn't happen until you've been admitted. And so people aren't getting admitted until like day 8 or 9 after they were exposed. And so then you have a test, which takes in some places 12 hours, and then other places are taking 5 to 7 days to come back. The data on how many cases we have could be running 2 weeks behind what's already happened. And then remember that the intervention you take is going to affect what happens 2 weeks from moving forward. So we're making decisions based on old data that, it seems like it's new data today, but it's really reflecting what happened a while ago to make interventions which are going to prevent problems moving forward. And so social distancing, the biggest reason this happens is that this virus spreads exponentially. And so it doubles every 2 to 3 days in terms of the number of cases. And so, going from 50 cases to 100 cases, that's not a big deal. When we talk about going from 10,000 cases to 20,000 cases in an area, you're going to swamp your healthcare systems. And especially if over the next 2 weeks, it continues to double every 2 to 3 days until measures can be pretty under control. That's what makes this a challenging disease process. And so that's kind of like, I think the importance of social distancing is that it's not what's happening today, it's what's going to happen in 2 weeks or 3 weeks from now, and trying to flatten that curve. So.
And to move forward on that again, we've got a lot of lower school families. I've got a second grader, right there too.
I got a
really misses, you've got them as well, who really misses their friends. And we're of course trying everything through technology to deal with that. In your professional opinion right now, should there be things like smaller play groups or anything that moving forward? Is there really a safe minimum number? Or, right now, is it really critically important that people totally isolate as much as possible within a family group, obviously, but between groups to help prevent that transmission, particularly since we won't know the implications of that for 10 to 14 days?
Yeah, I think that there's a couple sides to this, which is one is that if you truly can like lock down your circle like between two families and not have contact, it's probably fine, because like if you've truly isolated those two circles and those two circles interact, then they should be okay. But you still have to remember that those people still have to go to the grocery store, and so if they do get a problem, then it's gonna escalate, and it's gonna probably interact with both of those circles. I think Dr. Fauci, I think at one point had commented, head of the NIAID, is that if two families were very careful, that probably isn't totally unreasonable. At the same time, like my family definitely could not do that. We're trying to like figure out ways to not interact with anyone. And so I think if you still have if you're a part of somebody who's got like an essential job, I don't know if that's appropriate, because you're going to be out on a daily basis in the environment. And so you really need to look at like, what are all the access ways of people of this virus getting into your circle. And so, for example, Rachel and I, my wife's Rachel, and then so we, debating on like, do we stop coming home to try to like cut off the rest of our family from the circle? I could easily probably switch houses with my mother-in-law, move into my mother-in-law's house, she'd move to our house. And at that point, because she works primarily remotely at baseline before this even happened, if my wife did the same thing, we've also basically cut off our kids and our mother-in-law from the rest of the environment. Like I could even just bring them food if needed and leave it on the door. So there's a big challenge there with trying to find ways to like eliminate your circle and try to prevent it from coming in. So the bigger your circle is, the more likely you're going to get this. And so limiting those, definitely not beyond like one other family. And then you really need to be asking yourselves, what are the people in those families doing to try to isolate themselves from the rest of everything else.
Great. Let's talk testing for a minute. And so let's say I was going to walk into the ER tonight at Vanderbilt Medical, and I've got just a little bit of a cough and not feeling 100%, but don't have any major symptoms. Would I be tested tonight, or what would happen with me? And how is that looking more generally if you're looking throughout the country as well? So, testing, of course, has been a big deal. And then to add on to that question, to leap on, are we past the point where testing is actually going to become beneficial as we're moving away from containment and more getting to a scenario where, we're out there right now and it's going to be with community spread? Is testing even as useful as it would have been 2 or 3 weeks ago or a month ago?
So at Vanderbilt, we did some things at other institutions. We're a huge academic research center, so we have a lot of resources at our disposal that most hospitals just don't have. So we developed our own test. FDA gave us approval for it. We've been running our own tests. We've run a very large proportion of the states run in the state of Tennessee. Once we got approval for our test, we opened 8 coronavirus walk-in clinics. So actually, if you had called our coronavirus hotline, we would have directed you not to our emergency department with those symptoms, but to somewhere else. We would have swabbed you and sent a test. Talking to my ER colleagues around the country, that is the exception and not the rule. Right now, most places to get a test, you still almost always need to have a fever, a cough, and you need to be sick enough to where you're getting admitted to the hospital. So there's a little bit of a disconnect. And I think it's interesting as you look at Tennessee data, because we've done so many of these tests. Like I can compare Tennessee and Kentucky, they're 2 adjacent states. Kentucky doesn't have something like Vanderbilt going on, testing a lot of people in the community. If you look at their positive curve, it tends more towards the 50, 60, and 70-year-olds. Those are the people that we know are more likely to get admitted to the hospital with this. If you look at the Tennessee curve, we actually have a lot of 20 and 30-year-olds as the predominating number of people getting it, which if you think about it, there could be some differences in the age proportion of populations between the 2 states. That could definitely be contributing. But 20 and 30-year-olds are much more likely to be going out and about in public. They're much more likely than, say, like a 9-year-old to show signs of the disease. Like there's very few people even identifying young kids with this, because for some reason they do so well. It's like you don't even know they don't even know they have it. And so in the 10 to 20 range is kind of this also like kind of vague range where we don't even know if kids that age really have it a lot of times. And so it's interesting from a testing perspective. Is testing helpful? I think testing has been helpful for us in Tennessee because I think it's helped spur Nashville, Davidson County to start our lockdown hopefully sooner than it has in other places. So we're hoping that it helps reduce our overall curve locally. And then the other thing too about testing is testing changes behavior. And so if you have to wait 5 to 7 days to get a test back, which is a very common scenario for people right now, even in hospitals, like even Vanderbilt right now, we've done so many tests that we're having some backlogs that it's no longer we can get it back in our goal of 4 hours, which is, we're not even anywhere close to that right now. But so I know some places, you know, we have to send it to another facility, like a testing center, like LabCorp is one of them. So if you have to send the test out and it takes 5 or 6 days to come back, somebody who, you know, if we say like, oh, you may have coronavirus, it's a lot different than if like, no, really, we know you have coronavirus, and that changes who they, how they interact. We know this from like people with HIV epidemic, it changes behavior. If you know, if you're day like 4 of this and you're starting to feel better, you're like, I can probably go back to work. I don't really know if I have coronavirus. You're much more likely to go back to work. You're much more likely to let you go back to work. But if you know you have coronavirus, you're not going to go back to work, and it's going to reduce transmission. So from a public health perspective, personally, I think that more testing, more information lets people make better choices about how they isolate themselves and going back to work. From a, how do we get out of this on the back? So in the acute, when the wave hits, like in New York right now, is testing every single person helpful? No, they're already on full total lockdown. No one's supposed to be going out. They don't have enough tests anyways to test everyone that isn't being admitted to the hospital. I don't even know if they have enough tests to test everyone that's in the hospital. But during the acute wave, it may not be helpful, but getting out of the wave, it would be helpful. So if we actually get to the point where this is under control, you know, we'd like to be able to test everyone that has, you know, a cough or some kind of symptom. And the idea being that like, then we can immediately, if you show up with a cough and 4 hours later, I can tell you have the coronavirus, go home and stay home for 2 weeks, then that would prevent us, you know, prevent a second wave that some people have talked about in the future. So.
Right there too. Got it. Can you talk for a minute? We've had several questions brought up about herd immunity. And of course, you know, particularly, you know, we see it, herd immunity frequently brought up with childhood vaccinations, measles, et cetera. Why is herd immunity or you know, and I've also read somewhere with Britain perhaps trying to go that route, saying most people are going to get coronavirus anyway, so we're going to try and manage that and get as many people infected within reason as we could, so that hopefully we get that wave going through relatively quickly. Why is herd immunity not kind of a current option for the coronavirus at this time? Why would that be a bad idea? Would it simply be because of the overloading of the hospital system, or is there a bigger reason for that as well?
Yeah, I still think you're more likely to oh man, it's the Britain idea is terrifying to a lot of epidemiologists, and I'm not an epidemiologist. But I mean, even at, you know, like 1 in 500, if everyone in the United States, you know, if we have like 100 million people and 1 in 500 of them, you know, 1 in 500 is a death rate for the 20 to 30-year-old age. So 4 times that is going to get hospitalized, and that's still going to just overload our healthcare system. And we'll see excess mortality because we'll totally overload our healthcare system. If that'll happen at once. I mean, so the goal is at some level, we'd like herd immunity to come back. I think it'll be really interesting to see what happened in China. China clearly was not able to test all their people in Wuhan, anecdotally and based on the aggressiveness of the virus. So what is the residual herd immunity in China from this is going to be really interesting to see if they have a second flare as they release all of their, I mean, they've closed, I think today they closed all their coronavirus hospitals. They're kind of like back onto a normal medical front foot. And so it'll be interesting to see if they have a second flare as this move forward. So.
Got it. From right there. Let me throw another couple other things, kind of some quick hitters, because we're gonna go till 4:15. But Chris has kindly set aside he could stay a few extra minutes on top of that. There was an interesting question that popped up. Is there any sort of current data on expectant mothers and coronavirus?
The data that I most recently saw is really low, and the reason for that is that it just hasn't been around long. No one's had a 9-month pregnancy. There hasn't been anybody with 9 months. This hasn't been around for 9 months. So there was a little bit of data in late 3rd trimester people that babies seem to do okay. Obviously, as we move forward, we'll start getting more data about 2nd trimester, and I mentioned people who had pregnancies where this happened in 1st trimester. But I would say right now there is no data about expecting mothers that seems reasonable. I think our hospital we're starting to reassess our policy that about what are we doing with our healthcare workers that are pregnant. So I think we've right now decided that we're pulling them out of direct patient contact, not with just COVID, but all patients, because we're kind of reaching the point where we think all of our patients are going to have to be presumed COVID unless proven otherwise soon. And so that's a challenge. It's a challenge. And the answer is no one knows, I think, right now, to be perfectly honest.
So would you say that, in going back kind of to loop around the question you had before then as well, it's going to come back, the issue is that we're not 100% certain that what the immunity would be for an individual who's recovered successfully from COVID, from a COVID infection, of perhaps being reinfected as well?
I think the current hope is that it's unlikely that you're going to get reinfected. There was some kind of anecdotal about people who had the coronavirus and they tested negative and then they tested positive again. The test that we're doing, we'd like to think is perfect. We know it's not. We don't have enough data to say how perfect it is or how good it is. The other thing too is the way they test for this is called a nasopharyngeal swab. So you take a super large Q-tip and you ram it in someone's nose. And if they flinch or you don't really get it all in there, or maybe they just are having a good day, it's not, we know that people can get false negatives. We know that we have there was an ER physician in Seattle tested negative for coronavirus. 2 days later was on a ventilator from coronavirus and tested positive. And so you can get what we call false negatives, where the test result is negative and you really actually do have coronavirus. So we think some of those second hits may have been from that. The coronavirus itself, in terms of immunity, doesn't seem to be something that mutates, for example, faster than the flu virus. Doesn't have a lot of the mutation risk that the flu virus has. And so I think from that perspective, it hopefully is something that if you get it, we're hoping that you will get a long lasting immunity that would last in the years category, not just months.
And to piggyback onto that, what have you heard, or, of course, people are hoping for one point that we'll have a vaccine. I don't know if that vaccine is going to be a permanent version like we do for measles or something like that, as opposed to, say, your annual vaccine for flu. In terms of what you've heard in your professional circles, have you heard any news you could share in that direction? Obviously, vaccine development and implementation is usually a 1 year plus timeline, but any information you could share about that as well?
Yeah, I know they're racing ahead. Vaccine development, 1 year is would be the all-time record. Typically these are 5 to 20 year events. But with advances in technology, they're creating the mRNA vaccine a lot faster. I think they're cutting safeguards out. The Moderna started phase 1 human testing before they even had animal data that their virus was effective, because they're still growing the mice they need. So the mice that were used for SARS-CoV-2 already have the disease pattern that we need in order to test this for SARS-1, not SARS-2. But they don't have those mice. Are just kind of there's a small itty bitty colony of them. So in order to test on them, we need to grow the colony. So they're growing the colony right now. They'll start animal testing. It's kind of weird that the ethics behind jumping the animal safeguards is interesting. But I think right now maybe it's justified, although you always have to be careful when you start breaking ethical barriers to do things. You can sometimes you create more problems. So I think a year is a realistic but optimistic timeline for a vaccine that could be mass produced. So
understood. A lot of students, speaking of ethics, a lot of students have had questions about ethics, and particularly what we've read and heard about in Italy in particular. Have you had any thoughts or discussions, thoughts with your wife or discussions with your colleagues about some of the ethical decisions you would have to make, or what would happen into a scenario if Vanderbilt were put in a situation where you have to make some tough choices? What are your thoughts, or what goes through your mind when you're thinking about those sorts of things, where you may be very much in a situation of having to choose who's the more likely to survive?
I think that New England Journal of Medicine article actually just came out recently on the ethics of coronavirus and pandemic, and short resource. There's some general principles that I think apply, which is try to save as many lives as we can is probably the first one. The second one is probably trying to save the most number of years of life we can. So if I can't save everyone, then in general, you try to save younger people over older people. You try to save people who don't have lots of comorbidities and aren't going to live long anyway. So if you have a fatal cancer and you're going to die in 6 months, we have to make those decisions. I think that's where your hospital policy, you have ethics committees. I think Italy has talked about a policy where over 80, or there's a Charleston comorbidity index of 5 or greater, which is actually, those people are pretty sick. Or they're old and their expected life expectancy isn't very long. Is the people that they're trying to stop doing ventilators on first. But it's a challenging decision. Some of the ethical articles have talked about how we probably need to have an appeal if your family member is like not given one, or like we're talking about pulling you off of one. So those are all very challenging conversations that personally I haven't had to make yet, and I hope I don't have to. But ventilators, running out of ventilators is a real concern. There are not that many of them. People, I think, talk more about beds and ICU beds. I am much more worried about ventilators. We can put patients anywhere, and we can take care of patients anywhere. Vanderbilt's got a 60-bed garage ready to go for patients. I think the concern is will we run out of ventilators? So big efforts nationwide by every state to get more ventilators. Just perspective wise, when people are like, how many people are going to need ventilators and why social distancing is important. I can know the numbers in Tennessee have been published. So Tennessee has a population of 6 million. DFW and your surrounding area is probably 7.5. So I don't know. I couldn't find the DFW numbers. They actually said, I think at one point they're not going to release them, but let's just assume they're similar to Tennessee. We have about 1,000. So we're trying to get more. There's 1,000 ventilators across the entire state, and they're not like not being used. So maybe half of those are in use right now would be a not unreasonable estimate. And so when you think about the fact that 20% of these people end up being hospitalized, 5% of them get critically ill, and a good portion of those 5% are going to end up on a ventilator at some point. 1,000 people, if 1 in 50 needs a ventilator, which is like already at the death rate, right? So you multiply times 50 times 1,000. If we have 50,000 local cases, there's no way we're going to have enough ventilators. So I think that's one of the major concerns. And those are all very conservative estimates. So.
Got it. Got 3 last questions for you kind of moving forward. One of them is a quick hitter in terms of being asymptomatic yet still shedding virus. What's the current thinking on the amount of time between actual infection showing symptoms in that delayed range between which you've been infected but are not showing symptoms? Is the thought that right now you're also infectious for others?
Yeah, we definitely think you can be in the days before. I mean, that's a known. And I think once I read that, I knew there was pretty much no way we were going to contain this. It was going to go worldwide. The time frame of that, I think they're still trying to figure out. It's definitely probably not like the next day. So like I got exposed today, it's probably not the next day. Most people probably end up showing symptoms at the 5, 6, 7, 8 day mark. I think there's some thought that maybe they're really like infectious in the 1 to 2 days preceding it, but it could easily, I don't think anyone knows. And this virus is so weird. Like it is so weird. We just found out that like anosmia, so the inability to like smell and taste, most people in hindsight is like 30% of the cases. And so we at Vanderbilt just tested an employee who came up and was like, I can't smell or taste anymore. And we tested him and he had coronavirus. So no other symptoms, no cough, no fever, no myalgias, just I couldn't smell or taste. So are they truly asymptomatic? We just haven't figured out the symptoms as part of it too. And so there's a lot of questions. I don't think anyone knows the answer to how long are you contagious before you have symptoms? But the answer is definitely for some period of time. We just don't know.
Okay. Last 2 got for you. One is that in our school nurse, Amy Coates, has been asking an excellent question here that's been going around schools specifically. When do you think is the time, at some point you're gonna have to make the call to start bringing groups back together, start bringing schools back together. What do you think that reintroduction looks like? I'm not necessarily saying, when will that be? But when that reintroduction is decided, is it just everyone goes back to school the next day and hopes everything's going to be okay? Or what do you think is the procedure for reopening, reopening America as we start going to larger groups again at some point? What's the best way to do that? Or do you have any ideas about that?
I think that if we can widely test, we're going to want to try to have it to the point where we can test everyone early. And testing is still ramping up. We're still getting more tests, like it's getting better. Then I think that's the point where I think we can, and clearly we're on the decline in cases. can we try to get back into the game by testing, or kind of like testing and then isolating people that develop it, so we don't have another huge exponential surge or a second wave. In terms of like when do schools go back, it's probably reopen businesses first. Schools are probably the last thing to go. Unfortunately, I also think that we're also gonna, I don't know if we'll make it to, I don't know if we'll have school by the time summer starts, in which case we'll have a few months to figure this out. As we've talked about, it's like where we are today on cases. Earlier, we talked where we were 2 weeks ago. We have another 2 weeks ahead of that. And so we're still going to be on the uprise, and the uprise is going to continue for a while. So,
okay.
So I don't know. I think it's a tough question on how do you bring. My attitude would be is if we're going to reopen schools, you just reopen the schools and we go from there. So, but I don't know.
What are things that we can do in the community best overall to help the medical community moving forward? So what are things we can do as students and workers and parents? Is there anything specifically we could do to help the medical community overall?
Stay home, please social distance, then be mindful. I mean, we're here for you guys when you need us. This isn't the time to like, it's interesting. Doctors are trying to do more telehealth and try to reduce burden on us, but we also still want to like manage illnesses and stuff like that too. Like if you broke your leg, please come to the ER. But if you like kind of stub your toe and you're like, do I need to go or not? Maybe don't come. But I think social distance is probably the biggest thing for us. Support for us. I think there's a lot of like, I don't know, there's a lot of need. I think like childcare, this is going to sound silly, but like one of my not even ER attending friends, but one of my physician friends, like their nanny won't come to their house anymore. And so it's like, she's like, I can't get to work right now because I have 2 kids at home. She doesn't have, her husband works in Canada, is a physician in Canada right now undergoing training. So there are challenges for us with childcare. There's a lot of things in that respect that are difficult. So I saw it's like someone posted on there, like, would you accept meals and use meals that are catered from a local restaurant? I said yes. We always like food. Doctors like food. We all eat. But I think our biggest concerns are for us right now is making sure we can keep going to work. So things that help us do that. So like childcare and meals and just don't get sick. Please don't get sick. So.
Got it. Is there any last thing you'd like to say to the TVS community as we wrap up here? And again, Chris, thank you so much for your time. I know this has been very useful for our community, and just we appreciate it as I know Chris has got a shift tonight at 10 o'clock. So he's getting ready for that part there too. Is there anything you'd like to add into the community, or any words of wisdom or anything else moving forward as we begin to wrap up here?
Stay socially distant. We're going to get through this. Clearly this is going to be, one of my friends can't work right now because she has some medical issues. She's like, I feel like I'm missing out on the defining medical moment of our generation. And I was like, yeah, probably. And so it's going to be extraordinary or interesting times. But we're going to get through this. Stay socially distant, I think, is the best thing we can do right now to help, to try to reduce the spread, reduce what's going to end up happening. And then we're all kind of figuring this out at the same time. So we'll see how it goes. So.
All right. Well, Chris, thank you so much for your time today. And I know the Trinity Valley community appreciates this. I think we will have a cloud recording of this webinar, and it will be posted. And I'm certain that Ashley Robinson, who is responsible for all our social messaging, will get that out to the community. And again, I thank all the attendees for coming. And if you have any future questions for Chris, we might be able to bring him back at a later time. We'll see. We're in a very fluid situation, which is why we wanted to grab him for today. But people at the Trinity Valley community do have my email address from right there too, if you'd like me to pass along some thanks to Chris as well. And again, Chris, thank you so much for your time, and thank you everyone else, the TVS community, for being here. Keep socially distant, and we hope to see you guys in person sometime in the not too distant future. So thanks a lot, and have a great afternoon.
Awesome. Thanks, guys.